We're going to do part 2 today of the mechanical ventilation lecture talk. I did do this as an interactive session with the students. However, due to long breaks for breakout sessions and a lot of discussion, I'm also creating this video as a more streamlined approach to the material for anybody looking for a refresher on the second part of the content. So the objectives for this session in combination with the first session are to differentiate the components of the arterial blood gas relating to ventilation and oxygenation, looking at non-invasive and invasive respiratory support, looking at ventilator settings that need to be ordered and how they relate to ventilation and oxygenation, look at ventilator changes that need to be made based on how the patient's doing, and then also look at a few other additional common modes. So I would like to start off with a case. You're called about a patient who's post-op day 3 from a Hartmann's procedure. Saturations have dropped, increased work of breathing. A face mask was applied prior to your arrival. The patient's a little bit tachycardic. They're maintaining their blood pressure. Saturations are okay on a venti mask with an increased respiratory rate. He is responding to simple questions and commands with mildly elevated work of breathing. Respirations are diminished bilaterally, and his abdominal exam is unremarkable. So I'd like for you to pause for a moment. You might even pause the video and consider, what is your differential? What are your next steps in workup? And what are your next steps in management? In terms of a differential, this could be quite broad. Most commonly in this post-op day 3 patient, you have to think about atelectasis from splinting, pneumonia, fluid overload or pulmonary edema, as this is the time when fluids are often mobilized, PE, MI, also, as this is a classic time when there's more strain on the heart, or even a COPD exacerbation or other pulmonary event from an underlying pulmonary disease. Next steps in your workup should be guided based on your differential diagnosis. So you may get an arterial blood gas looking for an AA gradient. A chest x-ray is critical. You're looking for pneumonia, looking for fluid overload, or other unexpected findings. An EKG and troponin should be considered if MI is in your differential, as it should be. And then depending on your degree of suspicion, you may want to consider a CTA to rule out PE. It did come up as a question from one of the students about getting a D-dimer. And while a D-dimer is an excellent test for its high negative predictive value for patients coming through the emergency department, it's not as helpful in a trauma or surgical patient because the D-dimer is almost universally elevated in these populations. So with all things, you should always be thinking about parallel pathways. I've got one pathway of workup where I'm trying to get down to the bottom of, I'm trying to get to the diagnosis, but you also have to think about the treatment, the patient in front of you. How am I stabilizing the patient? And so a patient with increased work of breathing and desaturation should not be maintained on the floor. And so this patient I would transfer to the ICU at a minimum. Some people did consider intubating the patient at this point. Currently, the tachypnea was mild to moderate, and the increased work of breathing was described as mild, and he was responding to commands. So at the present time, you may not necessarily intubate. If, of course, you get a blood gas back and the CO2 is 80, then that might change your management a little bit, but or quite a bit. But at this time, the patient was not described as somebody who absolutely needed intubation, but certainly a higher level of care. And the remainder of your actions are going to be driven by the workup and your findings. So if you find atelectasis, pain control is going to be important. Pneumonia or sepsis, you're going to focus on fluids, cultures, antibiotics, and everything in the surviving sepsis protocol. Of note, this lecture is coming out at the time of the COVID crisis, and there are separate, though very similar, surviving sepsis guidelines specific to COVID patients, and I would recommend spending some time on those. If you find that the patient has pulmonary edema, then diuresis, of course, is important in limiting fluids. If you find a high degree of suspicion for PE, you may even start the heparin drip prior to confirming the diagnosis, but certainly if you confirm the diagnosis, you'll want to treat that with heparin, perhaps even thrombolysis or thrombectomy, depending on the clinical situation. And then MI, of course, you would treat that appropriately. And then the question again of escalating level of respiratory support. We covered this in part 1, but I will return to it again. For non-invasive respiratory support, at a minimum, you've got room air, 21% FiO2, with increasing levels, as you can see here. High flow nasal cannula and CPAP or BiPAP are all considered to be, non-invasive respiratory support. And most of the time, these have to be performed at least in a step-down level unit, if not an ICU. Of note, high flow nasal cannula is being supported as a means of supporting COVID patients. However, CPAP and BiPAP are not. CPAP and BiPAP are excellent for the care of COPD exacerbations and CHF exacerbations. They're very good in the medical population. In the COVID population, there is some concern about increased aerosolization, as well as the fact that if the patients get to this point, you should probably just be more aggressive about intubating them early. In the post-surgical patient, again, we avoid these measures oftentimes because of the higher risk for aspiration in our patients. Continuing back to our case, you've transferred the patient to the ICU. You find that he's fluid overloaded, but he's not yet responded to Lasix. He's now on maximum high flow nasal cannula, still tachycardic, still maintaining his pressure, but now he's far more tachypnic on maximal settings. He's becoming difficult to arouse. His breathing is labored. And the remainder of the exam is unchanged. Hopefully, you recognize that this is an indication for intubation. Getting an ABG won't change the fact that this patient needs to be intubated. I don't care what the ABG shows. Maybe he's compensating and it's not so bad. Maybe he's already past that point and has quite a hypercarbia. It doesn't matter. You need to intubate this patient. However, the ABG is helpful because that may help you to determine your initial vent settings or further vent changes. Discussing indications for intubation, hypoxic and hypercarbic respiratory failure, of course, are very common, and it's important in a documentation standpoint, billing standpoint, to actually state the type of respiratory failure. So do make sure to document it as such. Inability to protect airway due to mental status is commonly seen in trauma and also other situations. Unstable airway frequently happens, facial trauma, dental abscesses, epiglottitis, angioedema, post-op spine patients, many reasons for intubation from a concern over the physical airway itself. And lastly, shock is probably one of the most common reasons that we intubate patients in the surgical population. As a patient goes into shock for whatever reason, again, the cells are hypoperfused. They kick over to anaerobic respiration, which creates a lactic metabolic acidosis. In compensation for that metabolic acidosis, the patient tries to blow off CO2, so they become tachypnic. And at some point, that tachypnea turns into an increased work of breathing. They tire, and then they develop respiratory failure as such. So it's important to recognize shock as an indication for intubation. So for this patient, you've decided to intubate him, and the question is, what would you like for your initial vent settings? We talked about this in a bit. We talked about this in part 1. So please pause and think about what your initial settings would be for this patient. There's no perfect answer here, and I didn't give you all of the information about the patient, but consider what would be reasonable for a typical patient in these settings. Again, there's no perfect answer here, but some things to consider. First of all, FiO2, always start at 100%. You want to remove as many variables from the equation as possible and stabilize the patient as rapidly as possible. So start at 100% FiO2. However, that doesn't mean you walk away and then, not look at it until tomorrow. You want to watch that patient and titrate that down as quickly as possible to a much lower FiO2, ideally 40% or less. You can start with a PEEP of 5. Again, if you have a larger patient or a small airway, you might consider starting at a higher PEEP, like 8. If you're not able to titrate that FiO2 down rapidly, you might consider increasing the PEEP to 8 or 10 or more, depending on the patient, but typically that's a good starting point. I didn't tell you anything about the patient's size. We'll assume that they're average, and so 500 is a reasonable starting point. Again, keeping in mind that that may be adjusted depending on the patient. And I didn't tell you anything about a gas. Perhaps we didn't get one. And so you may start at a respiratory rate of 16, but keep in mind that if the patient was hypercarbic, that you might want to start at a higher rate, or if you have reason to believe that they're acidotic from shock, you may want to start at a higher rate to help them with that compensation as well. So now your patient's improved. They got a gas after your initial vent settings, and they'd like to know if you want to make any ventilator changes. So you've gotten the patient down to an FiO2 of 60%, PEEP is 5, tidal volume is 500, respiratory rate is 16, and here's your gas. The patient is saturating 92%. Their actual respiratory rate is matching your ordered respiratory rate, so that means they are what we call riding the vent. They're not initiating any additional breaths. And here's our gas. I'll pause for a moment as you consider what you would want to do and how you are analyzing this patient. So this patient has an acidosis. We can see that there's a respiratory component as he is still hypercarbic, but there's also a metabolic component as well. The bicarb is a little low. So we are not adequately compensating for either. In regards to oxygenation, the PO2 is a bit low still, but the saturations are okay. However, we're still requiring a higher FiO2. So if we break this down into the two components, keeping in mind this here, this is what we're using to analyze. The CO2 is going to reflect our ventilation. That's controlled by our minute ventilation, which is the product of tidal volume and respiratory rate. And we've got our PO2 and our saturations, which control our oxygenation, keeping in mind that from a patient management standpoint, from a delivery of oxygen standpoint, the saturation is more important. And those are going to be managed with the FiO2 and PEEP. So from an oxygenation standpoint, the oxygenation is adequate for perfusion because the saturation is okay, but the FiO2 is suboptimal. Currently, the PEEP is only 5, and so we have room to go up on the PEEP. We can increase that to maybe 8 or even 10 as we continue to try to drive down the FiO2 to 40% or less. Notice we're not making any of our changes specifically for PO2, we're making them for the saturation. With regards to ventilation, we can see that the patient is inadequately ventilated as he has hypercarbia and acidosis. In order to increase our minute ventilation, we may consider increasing our respiratory rate or increasing our tidal volume or both. If we increase our respiratory rate, we have lots of room to go as we are currently riding the ventilator, and our concern for breath stacking is probably low at this point. But do keep in mind that the increase in minute ventilation is a little less reliable when you increase your respiratory rate, because with each breath that you increase, you do still have dead space being ventilated with each of those breaths. If we increase our tidal volume, it's a little bit more reliable of an increase in minute ventilation, because all that additional tidal volume that we add does increase our minute ventilation. However, we do want to be cognizant of peak airway pressures. So what are peak airway pressures? We covered this lightly in part 1, and some of the feedback that I got was that we wanted to understand it a little bit better, so we are going to return to that. So peak airway pressures are something that you find on the ventilator, usually in the top corner. And they're a combination of a couple of things. Keep in mind that we're discussing volume control ventilation, where we are guaranteeing a minute ventilation. We are guaranteeing a particular tidal volume. However, each lung is going to be compliant. Each patient has different compliance of their lungs. And so at different points in their course, or different patients are going to require different amounts of pressure to get up to that tidal volume. And so the peak pressure represents the peak amount of pressure peak amount of pressure that the ventilator is providing to get to the tidal volume that you have set. The peak airway pressure is a combination of a couple of things. So we start with our PEEP, which is our baseline amount of pressure that's continuously being applied, end of expiratory pressure, and that's our minimum pressure that's always being provided. So that's the first component. And the second component is, like I said, the pressure to arrive at the tidal volume. However, that actually has two components as well. You've got the pressure to overcome lack of compliance in the lung, and you've got pressure to overcome airway resistance. So if the upper airways have a bronchospasm, or biting down on the tube, or a big clog in the tube, it will take more pressure to overcome that resistance. And that resistance and that pressure doesn't necessarily reflect a lack of compliance of the lungs. And so it's important that we actually understand how we can separate those two factors out. Because if we're concerned about a high peak airway pressure, we want to know, is this peak airway pressure high because those lungs are really stiff and we're worried? Or are those peak airway pressures high because the patient has a bronchospasm and we should be treating them with a bronchodilator? So you can perform what's called an inspiratory hold, and you can do it on yourself, or more importantly, you can do it on the patient. You can ask the respiratory therapist to do this for you, where an inspiratory hold is performed. The patient's breath is held at that maximal tidal volume. And what happens is that you see the increase in pressure to get up to that tidal volume, but then once that tidal volume is in, the pressure drops a bit to what's called the plateau pressure. And now, because there's no more movement of air into the lung, the pressure at the plateau is reflective just of the lungs themselves, not of the upper airways. And so it's similar to how it's easier to keep a balloon open than to blow the balloon up. In this way, you can separate that out. Typically, that difference is 5 or less. But again, in the case of bronchospasm or other upper airway obstruction or concern, that could be higher. So why do peak airway pressures matter? This could get far more in depth, but for the purposes of this talk, we'll keep it as simple as we can. So why do I care about peak airway pressures? Well, I care about peak airway pressures because when they're high, that causes barotrauma, further lung injury, and makes the patient worse. In terms of what level I'm concerned about, typically I want to keep the plateau pressures under 30. Now the plateau pressure doesn't show up in the top right of the screen on the ventilator, and so we look at peak airway pressures more frequently than we look at peak plateau pressures, but we want to keep those peak plateau pressures, those plateau pressures 30 or less, if at all possible, which means we want our peak airway pressures ideally to be less than the low 30s. If they're in the 20s, we're pretty happy. If they're decreasing each day, that tells us that the patient is making progress. If they're increasing each day, that tells us the patient is getting worse. Once they start to get into the mid 30s or high 30s, I start to get worried. And once they get into the 40s, we get exceptionally worried. So that gives you an idea of the scale of our level of concern. And at all times, we should be trying to minimize our peak airway pressures. So how do we do that? Well, first of all, we need to consider that in the tidal volume. So when you look at ARDS and the literature on ARDS, it's highly supportive of low tidal volumes and higher PEEP. Keep in mind, the PEEP also contributes to those peak airway pressures. However, in the case of oxygenation, especially difficult to oxygenate patients, we often need the high PEEP because we need that recruitment and we need that to maintain oxygenation. And a couple of points of PEEP increase won't usually have as much of a substantial effect on peak airway pressures as increasing the tidal volume. So the takeaways are that if peak airway pressures are elevated or increasing, you want to keep that in mind with regard to tidal volume. And you also want to keep that in mind with PEEP, but mostly with tidal volume. If they're high, we want to determine why. So this table outlines some of the differentials for high peak airway pressures, splitting it into low plateau pressures and high plateau pressures. So you can see that low plateau pressures, but a high peak airway pressure, all have to do with something in the upper airway. Mucus plug, bronchospasm, ET tube blockage, biting down on the tube. If the plateau pressures are high, then that means that the pressure is high even once you've gotten past the upper airways. And so that may be the lung parenchyma itself, something like ARDS, pulmonary edema. It could be extrapleural, like pneumothorax or effusion, but that's still beyond the upper airway. Or it could be the ET tube migrating to a single bronchus because now you're ventilating just one lung instead of two. So we're going to try a couple of examples. These were examples that were given to the students in a self-assessment. So what we'll show is some of the answers that were placed, and then we'll discuss what management strategies might be done. I will pause after each of these to give you a moment to think about what you would do and then discuss the answers. So we've got a patient on PRVC, basic settings. This is their gas. Their peak airway pressures are 18 and their actual respiratory rate is 16. Down in the corner here, I have listed the settings and the gas as a reference. The settings are usually implied. We don't usually have to list off every single label because with typical settings, you can tell what they are. The blood gas, of course, is standardized, but still there for a reference for you. So this patient has an acidosis. No metabolic component, but there is a respiratory acidosis. We can see that oxygenation is adequate with a saturation of 95% on minimal settings. So there is really no oxygenation issue, but there is a respiration issue. The patient has a hypercarbic respiratory acidosis. That means we need to increase their minute ventilation. Suggestions from the students included increasing tidal volume or increasing respiratory rate. Either of those answers are acceptable. The patient has low peak airway pressures, so there is room to go up on the tidal volume. They're also riding the ventilator, meaning their actual respiratory rate matches the ordered or set rate, and there's plenty of room to go up there. So you could increase one, the other, or both, keeping in mind that the increase in respiratory rate will perhaps be a little less predictable because you are increasing ventilation of the dead space as well, so it may not be a one-to-one increase in minute ventilation. But keeping in mind that with the tidal volume, you want to consider the patient's size. If this was a small patient and we're already at the upper limit of their expected range for tidal volume, then I would probably favor increasing the respiratory rate. If this was a taller patient and I thought we were at the lower limit of their acceptable tidal volume, then I would probably increase the tidal volume. Next patient, PRVC. These are their vent settings. This is their gas. And this is their actual peak airway pressures are 28 and respiratory rate is 16. You can consider what you would do. Pause. And as we analyze this case, we see that the issue is predominantly an oxygenation issue. So the patient does not have any significant alkalosis or acidosis. The respiratory and metabolic components of that are within normal limits. Their saturations are actually acceptable, and so at first glance you might think, oh, they're doing fine. However, when you look at their ventilator settings, they're suboptimal. The FiO2 of 70% is not acceptable, and so we want to work to drive that down. There are a few strategies we can take to drive that down. The first one is increasing the PEEP. So by increasing the PEEP, that will allow us, hopefully, to decrease the FiO2. Now, those were the primary answers that I was looking for from the students, so they did well. However, if we take this to the next level and really think about this patient critically, we want to consider that their peak airway pressures are approaching a higher range. Increasing their PEEP won't have too much of an effect on that, but if this patient is having an oxygenation issue, we also want to limit the barotrauma to this patient. And to do so, we might also consider decreasing their tidal volume, which will help to bring down their peak airway pressures. When we decrease their tidal volume, we may need to increase their rate to maintain adequate minute ventilation. So those are advanced considerations. But again, in optimizing this patient, the immediate events should be increasing the PEEP so that we can decrease the FiO2, and additional considerations may be to decrease the tidal volume and increase the respiratory rate in order to optimize the peak airway pressures. Here's the next question. Give you a moment to read that while I plug in my computer. So for this patient, we have a patient on PRVC, minimal vent settings. We do have some alkalosis with a pH of 7.59, and we can see that it is a respiratory alkalosis. The bicarb is normal, but the PCO2 is low. So this is a hypocarbic respiratory alkalosis. Peak airway pressures are fine, but we can see that the actual respiratory rate is 32, but our set rate is 16. So for a hypocarbic respiratory alkalosis, we want to decrease the patient's minute ventilation. So some students chose decrease the respiratory rate. And it is true, we want to decrease the patient's respiratory rate. However, ordering a decreased respiratory rate is going to do nothing. Keep in mind, with PRVC, every initiated breath becomes a fully ventilated breath. And so if I decrease this to 12, that doesn't change the fact that they're initiating 32 breaths. And if I get a gas in an hour, it's going to look exactly the same. So we want to functionally decrease their respiratory rate, but changing the order isn't going to help. So what else can we do? Most of the students did get the correct answer, which is to increase sedation. Again, I haven't told you everything about the patient, but we can make some assumptions. And increasing sedation is one of the best first ways to improve the patient's ventilatory status by decreasing the respiratory drive. Some students did choose decreasing tidal volume. Decreasing tidal volume mathematically will decrease their minute ventilation, so it's not completely incorrect. The only caution I would have there is that if this is an appropriate tidal volume for the patient, decreasing it might not help the patient. Sometimes we'll see a paradoxical hyperventilation, this is anecdotal, as the patient is given, a suboptimal tidal volume for their size. Sometimes that actually causes enough agitation that they end up having even more tachypnea. So if this is an appropriate tidal volume for the patient, most likely in this case, I would not decrease tidal volume. Most likely I would just focus on functionally decreasing the respiratory rate. Sometimes decreasing it is appropriate if we're already on the higher limit or higher range for a patient's appropriate tidal volume, then perhaps I would decrease it. Next question. I'll pause for you to read it, think about what you would do. So this patient is on, again, minimal vent settings. And what we find is a acidosis that is metabolic. So there's no respiratory component to it. However, the patient also is not compensating from a respiratory standpoint. Oxygenation is adequate with a minimal vent settings. Peak airway pressures are high. And so thinking about what to do for this patient, you might say, this is a metabolic acidosis. What can I do for them from a ventilator standpoint? This question doesn't belong. And to some degree, that is true. The first priority in this patient needs to be, why is there a metabolic acidosis? What do I need to do to address that? What is the source? So thinking like a surgeon, you should be thinking, what is my source? Is the patient bleeding? Is the patient septic? Sure, there can be other causes of metabolic acidosis, like diarrhea, renal failure, or pancreatic fistula. However, your top priority should be looking for bleeding or sepsis. That being said, in the immediate setting, you still can help to optimize the patient with the ventilator. So you can see this was a little trickier for the students. Lots of different things chosen. And so some of these are better than others. In this patient with a pretty profound acidosis, 7.12, you want to help with that as quickly as possible. And so while there is no significant respiratory component, there's also no significant respiratory compensation. And so the first thing we can do is increase the minute ventilation to help compensate for that acidosis. Now, which component of minute ventilation should we increase? We will, in this patient, increase the respiratory rate. And so, fortunately, that was the most commonly selected answer. We do not want to, at this point, increase the tidal volume yet because the patient already has high peak airway pressures. Due to those high peak airway pressures, we might consider why we have high peak airway pressures. They're actually oxygenating fine. Minimal settings with good oxygenation means we don't need to make any changes to the FiO2 or the PEEP. We're not going to decrease the PEEP to less than 5 even when the peak airway pressures are high. You might consider suctioning the patient, certainly to see if that helps with the peak airway pressures and gives you more wiggle room on the tidal volume. You might consider getting a plateau pressure to see if it's an upper airway bronchospasm type of issue or something else, perhaps pressure from a large pleural effusion, perhaps a pneumothorax, perhaps an abdominal compartment syndrome, other things that can affect that pressure that could also incidentally cause the metabolic acidosis. So you certainly need to do more investigations to determine why those peak airway pressures are high, especially if they're suddenly high. But the primary answer here is to increase the minute ventilation. A couple additional questions. I'll pause while you consider what to do. So for this patient on PRVC, we can see that the settings are relatively low. Tidal volume of 500, respiratory rate of 20, FiO2 of 50, PEEP of 8, nothing crazy. And we can see on our gas that the patient's actually doing great, a PO2 of 225. So that's a P to F ratio of greater than 400, saturating very well, and slightly hypocarbic. The actual respiratory rate matches the set rate, so we're riding the ventilator, and peak airway pressures are minimal. So you might say, what do I have to do for this patient? Everything's great. Well, we always want to be progressing the patient, and so in this case, instead of thinking about fixing things, we should be thinking about progressing the patient. And so the problem with this patient is they are going to have no reason to breathe. Their oxygenation is more than adequate, and they're a little bit hypocarbic. So they're going to have no reason for any respiratory drive. So in order to improve that, we're going to decrease our FiO2, maybe decrease our PEEP too, because we really don't have an indication for it unless it's a large patient or a small tube. And we're going to decrease our respiratory rate as well, all with the goal of getting the patient to initiate their own breaths so that we can progress them off the ventilator. How about this patient? I'll give you a moment, pause, and think about what you want to do for this patient. So this is a challenging patient. We have a lot of things to consider. At first glance, you can see that the patient is on pretty high settings. The FiO2 is 80% and the PEEP is 10. Despite that, their saturations are only 89%. Their P to F ratio is less than 100. And they have a primarily respiratory acidosis with hypercarbia and a pH of 7.25. To add insult to injury, their peak airway pressures are 42. They've already crossed into, a much more concerning range. So there's a lot of things that we want to try to do for this patient. Keep in mind, these are the patients that that we may be dealing with COVID or with severe ARDS. And so these are particularly the challenging patients where you spend a lot of time at the bedside making small changes. So here are some of the things to consider. First of all, we need better oxygenation. So we can try to go up on the PEEP. 10 is still on the lower range, but we are also considering our peak airway pressures. So we're going to increase our PEEP, but in order to manage our peak airway pressures, we also need to decrease our tidal volume. We are still going to try to drive down that FiO2 as much as possible. And we're going to accept a saturation in the range of 88 to 90 with the goal of building up at least a little bit of reserve. Now, normally, I change FiO2 in increments of 10%. In these very difficult patients, even 5% can sometimes be aggressive and tip them over. So I would go very gradually down on the FiO2 in increments of 5% after increasing the PEEP and decreasing the tidal volume with the goals of decreasing the peak airway pressures. In order to maintain and increase minute ventilation to address the hypercarbic respiratory acidosis, now that we have to decrease our tidal volume, we have to increase our respiratory rate even more. And so we're going to increase that as much as tolerated, while also being sure not to cause breath stacking. These patients become very difficult, and as a result, we find ourselves oftentimes having to use permissive hypercapnia, where we actually allow a pH in the 7.2s and a PCO2 in the 50s or sometimes even 60s, because that's the best that we can do, and we're trying to minimize our peak airway pressures. So this patient may end up requiring some permissive hypercapnia. Other management considerations for this very difficult patient that we discussed, proning can help with patients that are difficult to ventilate and particularly oxygenate, as it redistributes the west zones and helps to aerate lungs that are not well aerated. However, proning is very difficult, and there's other risks involved. Risk of loss of airway, in addition to requiring a lot of staff to flip the patient. If you're going to prone the patient, typically they're proned for 12 hours a day. If they're on the verge of coding, it's very risky to have a patient proned. And in the considerations of COVID, you also have to consider all the PPE that would be required by the staff to prone those patients so very regularly. There are some institutions that regularly prone patients that have beds that are specifically made for that purpose, and those institutions see better results because they do it more frequently. So proning is a consideration, but not one to be taken lightly. For a patient that absolutely cannot be oxygenated and has severe limitations with ventilation as well, with hypercapnia, ECMO is another consideration. That's a talk in itself. The thing to keep in mind is ECMO should be a bridge to something. And in these cases, typically we assume that it's a bridge to time, that if we give the patient enough time, that they'll hopefully recover the lung function and be able to be weaned off of the ECMO. But ECMO is something that would typically be considered once you get to a point where you can't oxygenate or ventilate the patient, but you think that they'll recover with time. Another mode that sometimes gets brought up, again, a talk for another day, would be bivent or APRV. The problem with bivent or APRV in a patient that's gotten to this point are two problems. One is that if there's any issues with hypotension or hypoperfusion, typically that transition to bivent or APRV is very rocky, as it requires high pressures and sometimes can cause the patient to decompensate. And the second problem is typically with bivent, we tolerate some hypercapnia to favor oxygenation. But if the patient's already hypercapnic, this mode will most likely make them even more hypercapnic. So without getting into the details of bivent or APRV, those are some of the considerations you'd have to make before even getting there. The last consideration is paralyzing the patient and putting them onto a pressure control setting. So paralyzing the patient will help with any dysynchrony, also can sometimes help with compliance, at least of the chest wall. And so sometimes that can be considered a rescue maneuver where you paralyze the patient for maybe 48 to 72 hours. Typically when patients are paralyzed, they're put onto a pressure control mode. Really volume control with pressure limitations or pressure control ultimately accomplish the same thing. They require a lot of constant evaluation by the intensivist, where if you're in a pressure regulated volume control mode, you set the volume and then you're limited as the machine approaches high pressures and limits those volumes, and you make adjustments to your volumes to limit the pressures that you're seeing on the machine. In a pressure control mode, you choose what pressure you're willing to tolerate, but then you watch the volumes, and if they're not adequate, sometimes you decide that you'll tolerate a little bit higher of a pressure after all. And so regardless of which mode you utilize, oftentimes you arrive at the same destination, and it's just a matter of how you're thinking about it. Regardless, it requires a lot of frequent reassessment in order to continually optimize the patient. Again, looking at the screen that you may be looking at for some of our ventilators, the peak airway pressures you look at here. If you were to do an inspiratory hold, which you can ask the respiratory therapist to do, the plateau pressure would show up in this region, and that would tell you what the plateau pressure is. The set rate is down here. The actual rate shows up usually on the side of the screen, and you want to watch the flow to determine how much room you have in the respiratory rate. So you want to make sure that that flow stops before the next breath starts. If the patient is still exhaling at the time of a new breath starting, then that means that you're going to be breath stacking. You're going to start to develop auto PEEP. And again, looking at the Drager ventilator, all the same things, you just have to find them in different places. So your peak airway pressure is now in the top left corner. You still look for your actual respiratory rate as compared to your set rate. And you can look at your flow to ensure that the patient is exhaling completely before the next breath is started. So that covers patients on a full control mode, the most common being volume control, either PRVC or VCAC. Along with how to make changes to the ventilator settings based on how the patient is doing and their blood gas, as well as management of very difficult patients. Hopefully, you'll see some patients improve. And so now we can just finish off the talk with a couple of cases of patients and modes for weaning. So the question is it time to wean the patient? So rather than thinking about time or not time to wean, instead, every day you want to be thinking, how can I progress this patient? And so even if the patient's on a full control mode, you want to be thinking, how can I progress this patient? How can I wean their FiO2 further? Are we in a good place with the ventilation? As we saw in that one example, the patient looked okay, but now we can progress them by increasing their respiratory drive. So you always want to be thinking about progressing the patient. But when we discuss weaning, it usually means getting over into a mode where the patient is initiating and doing most of the work of breathing. The topic of spontaneous breathing trials and weaning could take up a whole other lecture in itself, but instead we're going to focus just on a small portion of that, and that is looking at pressure support and how to assess the patient during the weaning. So in determining the patient going to a weaning mode, like pressure support, you want to look at their current vent settings. If they still have high peak airway pressures, if they are still requiring high FiO2, if they're still ventilating poorly despite measures you're taking, then you're not going to accomplish anything by pushing them to breathe on their own. Instead, your efforts should be focused on optimizing what you have and fixing what you can. However, if they're on minimal vent settings, then you want to wean them as quickly as possible to get them off the ventilator. You also want to think about the status of the problem causing them to be intubated in the first place. So if you return back to the indications for intubation, you know, is their shock, the source of their shock, treated or, you know, improving? Is their respiratory status improving, etc. So contrasting PRVC, which you now should be very familiar with pressure support, which is the most common mode used for weaning. PRVC is a full control mode, meaning no patient effort is required. The patient could be chemically paralyzed, they could be brain dead, they could be fully sedated, fully anesthetized, and this will take care of everything they need. Whereas for pressure support, this is what's called a spontaneous mode. So the patient needs to be breathing, they need to be initiating their own breaths. And PRVC, you set the FiO2, PEEP, respiratory rate, and tidal volume, as you've seen very well now. With pressure support, you still set FiO2 and PEEP. That's a given for pretty much anything you do. However, instead of respiratory rate and tidal volume, you set a pressure support. You can think of this as BiPAP, except with an endotracheal tube or tracheostomy in place. So with each breath the patient initiates, a certain amount of support is provided above the PEEP, but they determine how much tidal volume they're going to get as a result, and they determine their respiratory rate. So as we mentioned, patient controls the respiratory rate and the duration of inspiration, flow, and tidal volume. There's always going to be a PEEP. Again, the PEEP replaces what we naturally have with our epiglottis, maintaining a positive airway pressure that keeps the alveoli open. So you're always going to have a PEEP. And it's always appropriate to have a pressure support as well. If you think about breathing through a straw as you do an activity, that increased resistance, the Purcell's law, where resistance is proportional to the length and inversely proportional by a factor of 4, an exponent of 4, to the radius. You know, the patient is breathing through a thinner tube than they're used to over a much longer distance. And so the pressure support, once we get down to a support of 5 to 7, is usually what is required simply to overcome the resistance in the circuit. So how is the patient doing? First, you want to look at just plain a normal assessment of the patient. Are they having chest pain or shortness of breath? Are they agitated? And look at their vital signs. Are they tachypnic, desaturating, tachycardic, hypotensive, hypertensive? Those are basics. But then additionally, we want to look, how are they doing on the ventilator? So there's 2 things primarily that tell us how they're doing. One is regarding ventilation. So the Tobin index, or the rapid shallow breathing index, is a measure of ventilation. It's a proportion of the respiratory rate over the tidal volume in liters. And a low Tobin, or RISB, is optimal, meaning we want the respiratory rate to not be high or tachypnic, and we want the patient to take good large tidal volume. So we want a low numerator a higher denominator. And in Tobin's original paper, 105 was set as a relative cutoff. Does that mean they will fail if it's 106 and they will fly if it's 104? No. This is just a guide. Typically, when we're extubating patients, their Tobins are frequently around the 20 to 60 range. But occasionally we do extubate somebody with the higher Tobin. Keep in mind, these are adult numbers. And as you cross into the pediatric population or even the small adult population, these numbers no longer apply. The concept still applies, but not a cutoff of 105. The P to F ratio looks at oxygenation. So again, we're not going to titrate to the PO2. However, we can get good information from the PO2. So a P to F ratio of greater than 200 is optimal. Have we extubated patients less than 200? Absolutely. Are we a little bit more concerned about them? Absolutely. And so those are things that we consider. So here's a case. Returning to our patient from the very beginning, your patient's improved with diuresis and supportive care, transition to a pressure support mode with the current settings as noted. We would call this 45 and 5, or excuse me, 45 and 7. That's just kind of our normal verbiage where we assume that 40, or the first number is the FiO2, and then we're given PEEP and pressure support. So this is considered to be a normal low amount of support. This is a full spontaneous breathing trial at minimal settings. We see that the patient is breathing at a rate of 16 with a tidal volume of 400 and saturating at 95%. We get a gas, and this is what we get. So how is the patient doing? Answer that question to yourself first. You might use this as a guide. Assuming all of the above is fine, we can look at their ventilation and oxygenation, and we find that they're doing great. So with the Tobin index, or RISB, is respiratory rate divided by tidal volume, 16 divided by 0.4, because again, it's tidal volume in liters. We find that it's 40, that's great. P to F ratio is 140 divided by 0.4. That gives us 350, well over 300, wonderful. So what now? We had a successful spontaneous breathing trial. We should assess the patient for extubation. So these are all the things we need to consider. Why were they intubated? Is that resolved or resolving? We looked at the Tobin. We looked at the oxygenation. You want to look at the mental status. Are they following commands? People get intubated for inability to protect their airway. We should also be considering that when we extubate them. We want to consider the airway, meaning is there a cuff leak? Meaning if we deflate the balloon on the endotracheal tube, does air leak around it? Do you hear a gurgle? If you do, that means there's plenty of room in the airway. If you don't, it means you might need to reassess the airway itself. We want to consider their secretions. Maybe they have a successful spontaneous breathing trial, but the nurse says, yeah, I'm suctioning thick secretions twice an hour. Well, that patient's probably not going to be successful at this point with extubation, and that would be a reason to keep them intubated while we look at how we can address that. We want to think about logistical aspects. While we don't keep people intubated because they might go to the OR with ortho tomorrow, if they're scheduled for a case later in the day or first thing in the morning, well, it would be pretty silly to remove the tube just to have it go back in. So you want to think about that. And then also think about safety, risk of failure, and what resources are available. If you've got a high-risk patient who's just barely meeting criteria and it's 9 p.m. and 2 emergency cases are going in the OR, tying up all your anesthesia staff, perhaps that's not the best time to extubate that patient. So think about all of those things. This is an example of the protocol we use at ECMC that was developed a few years ago. This is a spontaneous breathing trial protocol with the goal of automating a lot of the spontaneous breathing trials so that we could extubate patients earlier in the day. and be ready to make those decisions on rounds instead of 4 p.m. when resources start to dwindle. And this is after a successful spontaneous breathing trial, how we assess for extubation and how we assess for risk factors. So you can pause this if you'd like and consider some of the things that make patients risky for immediate failure, delayed failure, and some of the ways that we may optimize their success, along with our extubation procedures. So that covers weaning in a very nutshell. I do want to just touch on 2 other modes that you may see. One is SIMV and one is volume support. SIMV is actually technically supposed to be stated with what support. So typically here when you see SIMV, it's SIMV with pressure support. So just to focus on that for a moment, you can think of SIMV with pressure support as a cross between PRVC and pressure support, where instead of setting 4 things in PRVC, you actually set 5. And the main difference is with PRVC, every single breath that the patient initiates is a pressure support breath, or excuse me, is a ventilated breath. Whereas in SIMV, the patient gets a minimum number of fully supported breaths that you set, but any additional breaths beyond that set amount that they initiate are pressure supported breaths. So if you set their rate at 12, but they're initiating 15 breaths, then those extra 3 breaths are going to be pressure support breaths. At first, I thought this was genius in a way of weaning patients, because instead of giving them all full ventilated breaths, they get a mix, and you can start titrating that down, the number of fully supported ventilated breaths, and give them more pressure support breaths. However, I would say in practice, it's not always well tolerated by patients, and frequently patients do better if you just switch them over to a weaning mode when they're ready. And I think some of that anecdotally comes from them subconsciously not knowing what sort of breath they're going to get. Am I going to get a fully ventilated breath, or am I going to get a wimpy pressure support breath at any given time? Some patients do well with this, typically ones that have been ventilated for a longer period of time and are a difficult wean. So there is a place for it. Some institutions or intensivists use it very frequently. It's very region and intensivist specific, but you may not see a ton of it. The way to think about it again is if you set your rate higher than what the patient is initiating, then the patient's not going to get any of those extra breaths, and it's essentially the same as PRVC. If you set your rate very low, sometimes the minimum is 2, but if you set it theoretically at 0, then you're not giving them any of the ventilated breaths, and it's going to be pressure support. And then the rate anywhere in between is going to either favor one or the other, depending on the patient's drive. The other mode that I think is worthy of mention, because you may see it, is volume support. So PRVC is volume control, or VCAC is volume control. Volume support means that this is a spontaneous mode where the patient is initiating the breaths. You set FiO2, PEEP, and tidal volume. The difference for this mode is that you do not set a respiratory rate. The patient has to initiate every single breath. However, in contrast with pressure support, you are guaranteeing them a tidal volume, and the machine will give you whatever pressure is necessary to get up to that tidal volume, of course, within certain limits. For that reason, it's a little less aggressive in terms of weaning than pressure support. With pressure support, you can challenge the patient with minimal pressure and see how they do, and then assess them for extubation. With volume support, you determine an acceptable volume, and then you look at the pressure that it takes for the patient to get to that volume. So you can wean from this mode. If you watch the patient from day to day on volume support and you see that they're requiring less pressure, they have lower peak airway pressures, they're requiring less pressure to get to that volume, you can consider that to be progress. And if their peak airway pressures are 10 or 12 with a PEEP of 5, then that's telling you that that support being provided is really only 5 to 7, and maybe that patient is ready for extubation. So it's a little bit more confusing to think of as a weaning mode. It's certainly slower from a forcing progress standpoint, but for some patients, it helps as a slow mode or weaning, or at least makes you feel like you're doing something. I have some practice exercises here. Again, we'll pause after each one and discuss the results. I'll pause while you look and decide what you would do. So this patient has an acidosis that is both respiratory and metabolic, in addition to a high FiO2 with a low PEEP and just barely adequate saturations. So first, looking at the ventilation, we've got a combined metabolic and respiratory acidosis. We know the patient has a pneumonia, so we have theoretically a source for the metabolic acidosis. We're going to treat that with surviving sepsis protocol. However, we can also help to optimize the patient by increasing the minute ventilation. We have room to go up on the respiratory rate. Note that the patient is already breathing at a rate of 20, so we may want to go up a little higher than that. We also have room to go up on the tidal volume as the peak airway pressures are only 18. We don't want to go crazy, but there is room to go up on both, so we do want to increase our minute ventilation to help with the acidosis. Additionally, the patient is saturating okay, but we have a suboptimal FiO2. So we're going to increase our PEEP so that we can drive down our FiO2 as tolerated. If we haven't already, we would get a chest x-ray, making sure there's no mucus plugs or other things requiring immediate intervention, making sure that the endotracheal tube's in good position, etc. Make sure that we're suctioning the patient adequately. Next case, I'll pause while you consider what you would do. Okay, so this patient, we can see, has an alkalosis. It's hypocarbic. We have a respiratory alkalosis. Everything else is fine. We see that the patient's actual respiratory rate is 28, but their set rate is 16. We need to improve by decreasing their minute ventilation. Changing our order for the rate isn't going to help because they're initiating too many breaths. For a head injured patient, we want an optimal CO2 around 34 to 38. So increasing sedation or even chemical paralysis sometimes is necessary. But increasing sedation would be our first step for this patient. Next case, I'll pause while you consider what you would do. So this patient is ventilator day 10, stabilized, recovered, getting his spontaneous breathing trial, pressure support 55 and 5. We see the gas is excellent, good ventilation, normal pH, adequate PCO2, and really exceptional oxygenation. So the patient's respiratory rate is 16, tidal volume is 400. We're going to analyze how this patient's doing. So from a ventilation standpoint, 16 divided by 0.4 is 40. Excellent, Tobin, good. From a P to F oxygenation standpoint, 185 divided by 0.5 is 370. Over 300 is great. So this patient is getting close to extubation. In preparation for extubation, we still want to decrease the FiO2. We don't want a big change at the time of extubation, and so we want to decrease that FiO2 to 40% or less in preparation for extubation. We consider this to be a successful spontaneous breathing trial. We do not need to get any more blood gases. Look for criteria. Is the patient awake following commands? Are the secretions manageable? Is there a cuff leak present? And have we resolved important issues? If so, pull the tube. Next case, I'll pause for a moment while you consider. So this patient, same settings as the last one, same situation as the last one, except on this patient's spontaneous breathing trial, the respiratory rate is 32 and the tidal volume is only 160. We can see that the Tobin index, or the RISB, is too high. 32 divided by 0.16 is 200, too high. Hopefully you didn't require a formula to recognize that, and if you were standing at the bedside watching the patient breathe at a rate of 32 with a rate of 160, you'd probably pick up on something going on. From an oxygenation standpoint, the patient is fine, no big deal. So we need to optimize this patient. This is a failed spontaneous breathing trial due to tachypnea and poor tidal volumes. So we're going to return this patient to increased support. That may mean going back to PRVC, or it may mean pressure support, but with a higher level of support, perhaps 5 and 10 or 5 and 15. And then we're going to look at what we can optimize for this patient. Do they need diuresis? Do they have a pneumonia brewing? Are they optimized from a sedation and agitation standpoint? And if it's a primary pulmonary issue, then the literature would suggest, though it's not definitive, it would suggest that you probably should just wait until the next day. Additional repeated pressure support trials or spontaneous breathing trials in the case of a patient who is not ready from a pulmonary standpoint are probably just going to stress the patient more and take more of a toll on their system than allowing them to rest while you fix what you can. If the patient has failed for apnea or agitation, and those are things that we can fix because they're things that we caused, then trying again later is reasonable and appropriate. Next case, last case. I'll pause while you consider. So this patient has a mild respiratory and metabolic acidosis. However, the acute issue is desaturations. We can see that on a pressure support of a FiO2 of 50% and a PEEP of 5, the patient is only saturating 84%. Recalling those parallel pathways that we talked about, we want to treat the patient in front of us. So in the short term, we should increase our FiO2 and perhaps the PEEP to get that patient into a safer range of saturations, at least 88 to 90%. But we also want to determine the etiology. So our differential diagnosis is probably pretty broad. Mucus plug, bronchospasm, PE. Could have pulmonary edema. It's less likely to be acute unless there's MI with acute CHF. And could be pneumonia, although that's less likely acute also. So we want to look for what the peak airway pressures are, suction the patient, get a chest x-ray, get an ABG, consider a CTA, consider trope EKG echo. This elderly patient with mesenteric ischemia has a very broad differential diagnosis of things that can be going wrong, and we should be looking at all of those. That concludes today's talk. There is so much more that we could talk about. Troubleshooting the ventilator, further discussion of peak airway pressures, discussions on synchrony or dyssynchrony with the ventilator, and further discussions on what to do for desaturations. Additionally, we spent some time on it, but there's so much more we could go into on patients that are difficult to ventilate. Patients with COPD, of course, have additional challenges as their expiratory time is longer. Patients with ARDS we touched on, and those are quite complex. We did not talk about bivent or APRV other than to discuss contraindications to it, but that would be a talk in itself. And then finally, timing for tracheostomy, we did not talk about at all, but there's a whole other area for discussion there. So those are some things to think about. Hopefully you came away from this now having a much better understanding of assessing and managing the patient on volume control with pressure regulation, making recommendations for initial vent settings as well as ventilator changes based on how the patient is doing and their blood gas, as well as how to progress these patients working towards weaning and ultimately extubation. Thank you.